And we have moved on to contact stomatitis, and we have time to talk about mechanism and sources of antigen. You'll remember that this is the oral mucosal counterpart to contact dermatitis. It is a type 4 hypersensitivity reaction where the antigen is absorbed into the oral mucosa, and we get the reaction at the site where we have contact and absorption with the antigen. It's not a systemically circulating antigen or anything like that. And are antibodies involved? No, because it's type 4, which means it's cell-mediated, entirely cell-mediated. Where we pick up our discussion of contact stomatitis is with the clinical presentation. So most patients who have contact stomatitis will start out with an acute reaction. They might not figure out what's causing it, and it can become a more chronic, sustained reaction over time if they don't recognize that it's a reaction to something and eliminate the antigen. But regardless of if it's an acute onset and they just started having it or they've had it a little bit longer, the single most common complaint as far as symptoms is burning pain. It usually produces a burning pain. It's often not a really severe pain. Sometimes patients will describe it a little more like a sensitivity even because it's a milder pain. But these are painful lesions to some degree for most patients. They present typically with red changes. Why would they have red changes? Because it has inflammation, and so that usually brings on some redness. Some patients will get some white surface changes. The white surface changes are usually present in more severe reactions, particularly reactions that have been there longer and have become more chronic. So the fresher it is, the newer it is, the more likely it is to just be red. If there are white changes, those do not usually scrape off. The white part is part of the surface and just stays there. And in really severe cases, there can be erosions where we have partial loss of epithelium, not the full thickness of epithelium, but some of it. And in really, really severe cases, which aren't very common, you can even have outright ulcerations. Most patients don't get that bad. They usually figure out something's going on and kind of end up changing things so it doesn't happen. One of the trends that we see with the red lesions is that the tissue tends to be thickened a little bit and often has a delicate granularity to the surface. So the recruitment of all those inflammatory cells, which are going to be lymphocytes and macrophages, tends to produce some thickening in the surface epithelium. Depending on what the source of the antigen is and how they're exposed, sometimes the reaction can also extend to the lips and the perioral skin. If it involves the lips, it has its own name, contact chylitis. Chylitis refers to something inflammatory on the lips. And then, of course, if it's on the skin, it's going to be our traditional contact dermatitis. But the intraoral mucosal part is called contact stomatitis. So I brought some examples. This was a patient that we saw here at Loma Linda in the 1990s, so it's been a long time. She came in complaining of sensitive gums, only sensitivity on her gum tissue, nowhere else in her mouth. She said it had been there maybe a couple of months, maybe only 6 weeks, 6 to 8 weeks maybe. My colleague, Dr. Thompson, saw her. He's coming while I'm gone. He's going to lecture on oral infections, so you'll get to meet him. This was his patient. he looked in her mouth and he saw red changes, and notice how they're kind of grainy and pimply, just a little bit, just on the gingiva. Well, the symptoms and that appearance is strongly suggestive of a contact stomatitis, and when it's just on the gingiva, we think about antigens that are just on the gingiva. What is the antigen most likely to get on your gingiva and not really elsewhere? Think about it. Toothpaste. So the location strongly suggested toothpaste. So he questioned her and asked her if she had changed brands of toothpaste. No, she was sure she hadn't changed toothpaste. And they couldn't come up with anything. But he was sure it was toothpaste. And so he thought, well, he'll try some treatment. This is a contact stomatitis. It will respond to topical steroids. He prescribed some fluocinolone gel that we talked about using for aphthous stomatitis. Apply the gel with your finger to the gum tissue, and saw her back in 2 weeks. Is it better or worse or the same? Better. Quite a bit better. So that really kind of confirmed his suspicions that it had to be an inflammatory, immune-mediated kind of response. We started asking her more questions, back to the toothpaste. And that's when it hit her that although she had not changed brands of toothpaste, she had changed formulas. And it was when Tartar Control Crest first came out and she had switched to the Tartar Control formula. We now know that what so many patients were reacting to when Tartar Control Crest first came out is the flavoring, the artificial cinnamon flavoring. So he had her stop using the Tartar Control Crest, and this is what it looked like a few weeks after that, completely stopping the toothpaste. And what this little sore is about, we don't know. That was incidental and unrelated. So, treatment for contact stomatitis, best treatment is to identify the allergen and stop the allergen. Because it is a cell-mediated response, it does not respond as quickly to withdrawal of the antigen as a type 1 hypersensitivity. It can take some weeks to completely calm down, and so a lot of times we do use topical steroids to help speed resolution of the lesions. Which steroid you use, if it's a rinse or if it's a gel, depends on the extent of the lesions and how easy it is to directly apply versus swish and spit. So that was Tartar Control Crest. This was a patient I saw some years ago, and she developed soreness under her denture after she got a new denture. She had worn dentures for many, many years, had the same pair for decades, like about 30 years, and they got very loose. So she went to the dentist and got a new denture, and as soon as she got a new denture, everything was sore underneath. And at first they thought it was a fungal infection, and they treated her for that. Nothing happened, so they sent her to me, and it was interesting that the redness followed the contact pattern with the denture perfectly. She even had some red spots on her cheeks where it rested against the denture acrylic. So we had a suspicion that this might be an allergic reaction to denture acrylic. That is exceptionally rare. We tried putting some steroid in her denture to see if that helped it. It helped a little bit, didn't get rid of it. We actually ended up doing a biopsy on her to confirm the diagnosis. And this was an allergic reaction. So what do you do for a patient who's allergic to denture acrylic? What alternates are there? Implants, if you can afford them. She was on Denical. No, not going to pay for it. So at the time, the only other material you could get for dentures was the vulcanized rubber, and they cost like $5,000 a set. And there was only one lab in the whole country that still made them, and you can't get alcohol on them because it dissolves the rubber. So that wasn't an option for her because she didn't have any money. So we ended up asking one of our prosthodontists to make her a denture out of light cured material that was a little bit different formula of acrylic, and she tolerated that a lot better. It wasn't perfect, but it was a lot better. She still had to use topical steroids every now and then to calm it down. So it was very, very difficult to manage for her.
How long was the denture that she had before?
The old denture? She had never had a reaction to the old denture. But materials change in 30 years. So the most likely reaction you get to dentures is that they have excess monomer that didn't get reacted and you're actually getting burned. And that's easy. You can just reprocess the denture. We tried that with her. It didn't help at all. But true reactions to denture acrylic are very rare. But lots of different things are possible. You just have to think about what's going in the mouth. The location of the lesion sometimes is a big clue, and try to figure out what it might be. This was a patient, an older adult male, who complained of burning in his mouth. He had burning on his gum tissue, but he also had a lot of burning pain on his cheeks, both sides. And you can see that there's a lot of redness, some thickening, and here we have some ulceration. See how it's that tan color and a little bit depressed? That's an ulcer. And here's some white next to it, and then red around it, but it was burning pain. So asked him a lot of questions. So what touches the cheeks and the gum tissue? Kind of at the same time, but not so much other places. Would you expect it to be toothpaste or mouthwash? Probably not. What else? Gum. Tobacco is usually just on one side or one spot if it's chewing tobacco. But that's something to think about if it's just one side. But this was both sides and kind of around on that. So we suspected gum and got a good history. And he had just found a new favorite gum, Big Red Chewing Gum. And again, it's full of that artificial cinnamon flavoring. So that one's very, very antigenic, causes problems. And this completely resolved when he switched to a different flavor of chewing gum. Yes?
Only the cinnamon flavor?
The cinnamon flavor is one of the more frequent culprits. That we see it enough that we always ask about it. I always ask my patients, if I suspect they have a contact stomatitis, I always ask if they chew gum or eat a lot of candies and what flavors. Because it is one of the most notorious things that we see for contact stomatitis. There is another clinical pattern of contact stomatitis that is still a type 4 hypersensitivity reaction that you need to know about, but we see much less commonly. It is called lichenoid contact stomatitis. Lichenoid means looks like something else. This clinically looks like lichen planus in the mouth. Lichen planus is a disease that you're going to probably know about by 3 o'clock today because it is on the list of skin diseases we see in the mouth that Dr. Grandi is going to discuss. If you don't see it today by 3, you will see it Wednesday morning. It's one of the more common skin diseases that we see in the mouth. But it is famous for producing kind of white lacy changes in the mouth. Not so much red, but white lacy changes when we have lichenoid contact stomatitis. Lichenoid contact stomatitis is a reaction that we tend to see as the pattern of contact hypersensitivity to metals in the mouth. It can be to amalgams. That's probably the one that the most people are sensitized to, but it can be other metals as well, base metals, PFMs with base metal substrate that has nickel in it. We can see it where anything touches the base metal. And some patients are even allergic to metals in high noble crowns. But when we have a lichenoid contact stomatitis, we get mucosal lesions directly where tissue contacts the restoration. And it's going to have that white irregular pattern. This one's a little more classic lacy. This one looks more spotted. It's kind of interesting. But they're still confined to the area that physically contacts the metal restoration. So when we see that pattern, we don't just call it contact stomatitis. We add that extra word, lichenoid contact stomatitis. Sometimes we have to biopsy these to see if it's a hypersensitivity reaction that we can treat just by changing out the restoration to a different material, or if it really is lichen planus, which is usually autoimmune and isn't going to respond to new restorations of a different material. So this is a patient that one of my colleagues saw. This was a 12-year-old girl who started orthodontic treatment, and as soon as she got brackets placed, she started getting sores on her cheeks. So she went back to the orthodontist, and what did the orthodontist do? Anybody who's had ortho treatment knows. Gave her wax. Because those brackets, even though they're fairly smooth, they don't feel smooth to the cheeks, and they can cause some physical injury. So they suspected a physical injury, kind of a traumatic mucositis, but covering everything with wax didn't make any difference whatsoever, and the lesions got bigger and bigger and more persistent, ended up having to be biopsied to figure it out, and ended up being a contact stomatitis, an immune-mediated reaction to something in the brackets. So what are metal brackets made out of? They're stainless steel. What do most people have these days? Does everybody get metal brackets? No, anything that shows up isn't very popular. Porcelain brackets are much more popular these days. But the metal brackets were stainless steel, and stainless steel has nickel in it. And nickel is a really, really common metal to produce a type 4 hypersensitivity reaction. So what they did with her to finish her treatment was change out all the brackets to porcelain, but then they had to find something to do with the arch wire, because the arch wires are also stainless steel that have nickel in them. They tried titanium, but even the titanium had enough trace nickel in it that she was still having a reaction. So in order to finish her treatment, they actually bent the wires and sent them to a lab to be Teflon coated. And then they put them in her, and then she could have her treatment. So it was quite a process that she had to go through in order to safely have her treatment and not have a reaction. Nope, it was only an immune-mediated reaction. So they suspected injury, because don't injuries make red things too? Sure. Injuries and allergies can look a lot alike. That's why we kind of teach them back to back. So what's one of the key things about injuries that helps you distinguish it from an immune reaction? It heals quickly, and then it's gone. And things that are more persistent are more likely to be immune-mediated. This is another patient who complained of bad breath and white lesions for 1 month duration. And she had red and white changes on her cheek, and both sides, and white changes on the lateral border of the tongue. And this one was kind of stumping everybody, but then they got a little bit better history. Which came first, the bad breath or the white lesions? Well, the bad breath came first. Well, what were you doing for the bad breath? I was chewing gum. And it was cinnamon flavored gum again. And this is what it looked like a week after stopping the gum. So healed pretty quickly. This is a little bit faster resolution than most patients who have a contact stomatitis. It can take longer than that. The longer they've had it, the longer it takes to resolve as well. So let's move on to something else. Our recurrent aphthous stomatitis and our contact stomatitis are the two most common allergies that we see in the mouth. There are a few other much less common ones that we have to at least mention. Stomatitis medicamentosa is the diagnostic term that we use when a person has oral lesions as part of a type 1 hypersensitivity reaction to a medication or chemical that is circulating systemically, which means you either got injected with it or you swallowed it and it was absorbed into the bloodstream, but it's circulating throughout the body. And it's a type 1, almost always a type 1 hypersensitivity reaction. Occasionally it's one of the other types, but it's not a type 4. Even if it's not a medication, we still use the term stomatitis medicamentosa, but it's not very common. So common reactions that are systemic type 1 hypersensitivities to a medication or drug are skin lesions, hives, and other patterns of rashes on the skin. And so patients with stomatitis medicamentosa often have a skin rash too, but we use this term specifically for the oral lesions. And a lot of patients who have a systemic reaction type 1 hypersensitivity to a medication or chemical do not have oral lesions. They only get the skin lesions. So stomatitis medicamentosa is not particularly common. Sometimes it's a reaction to a medication that the patient had once before and they're having it again, and maybe it's been a while since they had it. They don't know that they got sensitized the first time they were exposed. Sometimes it's a medication they've been taking for a long time and tolerated and had no problems with, and for reasons nobody can explain, they have now become sensitized. And those are the hard ones because you can't figure out what it is. It makes it really difficult to figure out what it is. But these are reactions that develop quickly. Our contact reactions develop more slowly and hang around longer. Our stomatitis medicamentosa, being an immediate type hypersensitivity reaction, develop signs and symptoms quite quickly, usually within minutes or hours, and often do have a skin rash. This was a patient with a rash, type 1 hypersensitivity to codeine. This one was procaine. Procaine, have you heard of procaine? What's procaine? It's a local anesthetic. Do we use it anymore? No. Lots of people were allergic to it, and it was really something in the vehicle. Preservative. Wasn't it preservative? I think so. This is a patient with a penicillin reaction. Penicillin induces a lot of allergic reactions. It's famous for allergic reactions. And this is more of a hive-like, almost an erythema multiforme kind of pattern of skin rash. But this patient had oral lesions as well. Same patient. See how it's red and eroded and partially ulcerated in the mouth. So there are a lot of different ways that the oral lesions can look when a person is having a systemic reaction to a medication and have oral lesions. Very often it's red and ulcerated. Ulcerations are probably the single most common pattern. And if it's an acute reaction and it develops in the mouth at the same time that the skin rash comes about, it's usually pretty obvious what the culprit is. It's just harder to figure out when it's a patient who's been taking a medication for a long time and never had a problem. This is a patient who had a reaction to iodine. Iodine is sometimes used in medical procedures. It's used as a scrub before surgery. It's also included in some of the dyes that they use for radiographic studies. And a lot of people are allergic to iodine. And this patient has ulcerations and swelling around them. This is a patient who is allergic to sulfanilamide. I don't care if you know what sulfanilamide is. That's not so relevant. It was a medication, but it just had multiple small swollen areas. So this is kind of what we would call a localized anaphylaxis, where we get localized edema from histamine release and increased vascular permeability. So it's mostly those types of lesions in that patient. So there's a lot of variability in how it can look. This was an adult female, postmenopausal, taking estrogen replacement therapy. She was diabetic and on insulin injections. She had high blood pressure and was taking hydrochlorothiaze. All of those were medications she had taken for years. No changes in her medications, but she started getting ulcerations in her mouth, redness and ulceration and soreness. So which of those medications is most likely to be the culprit? Estrogen and insulin are uncommon things to produce reactions. They're too close to a normal hormone, and it's unusual to react to those. So the most suspect thing was hydrochlorothiaze. Could the dentist tell her to stop taking her blood pressure medication? No, and I think that's the point on this one. Even if these patients come into a dental office and the dentist is able to come to the point where it's a suspected reaction to a medication, unless the dentist prescribed it, the dentist cannot tell the patient to stop taking it. So this is when we have to consult with the physician who's prescribing the medication and say, we think this patient's oral lesions are a reaction to the medication. Can you try a different one? So how long do physicians want to try something? Sometimes they'll do it, but they'll give you like 1 week, and sometimes 1 week isn't enough. You have to give it a little time. patient who was getting new dentures here at the dental school years ago. And like with so many things that dental students do, the first impression wasn't perfect and had to be retaken. Have you heard of such things? And they were using ZOE as an impression material. That actually makes a really nice impression for complete denture. And it's hard to get off of the impression tray when you have to retake your impression. They ended up taking her impression several times, and they cleaned up the impression trays with orange oil to get the ZOE, the zinc oxide eugenol, off. And the patient came back the next day with very painful oral lesions. So the question was this a chemical burn from all the stuff that they put in her mouth, or was she having an allergic reaction? And is it a contact reaction, or is it a type 1 hypersensitivity? So what did you learn that a burn should look like, chemical burn? White first, and if severe, red second. Red around the white. She's got both. Which came first? She didn't know. If it's an allergic reaction, we can have red and white. Red tends to come first for allergy. So is it a contact reaction, or a burn, or a systemic reaction? Do we need more information? Yes, we need more information. So when we examined her, she had a rash on her face, swelling around her eyes, rash on her hands, and a few other places on her body. If it was a chemical burn, would she have a rash on her face and on her hands? No. So that fits with hypersensitivity reaction. Which one? A contact hypersensitivity or a systemic hypersensitivity type 1? It fits best with a systemic. So that's how you kind of sort through your case trying to figure it out. You look at the information you have and you come up with whatever it fits with this. Was that an easy case? No, it wasn't. Would I expect a hygienist to figure that one out? No, I think not. Actually, they consulted, even the dentist didn't figure it out. They had to consult with a specialist on that. But it's a really good illustration of the things you have to think about and how you kind of sort through, well, it looks like this. These are the things I know of that look like this. This is the information I have that points to this one, but not to that one. Because your first quiz on Friday, you're going to have to be applying kind of those thinking patterns. So help me sort of practice that. This is what she looked like a week later. And it's healing very nicely and no further reaction, no further exposure. So she's doing good. Decided it was a stomatitis medicamentosa as part of a systemic reaction to something. A lot of people react to Lichenoid. A lot of people are allergic to Lichenoid. I want to move on to angioedema. Angioedema is not particularly common. It actually is a little more common in recent years than it used to because of some medications that have become popular that can trigger it. When I was in dental school, they called it angioneurotic edema because they thought there was a psychosomatic component to it, but we now know that that is not true. And angioedema is most often immune-mediated. We use this for a reaction that produces localized swelling in the tissue that develops very quickly and often resolves in just a few days. Typical time frame that it lasts is about 3 or 4 days, occasionally a little bit longer, sometimes resolves within 24 hours. So it's a fast onset, fairly quick resolution type of condition, and it is localized. It is not everywhere on their whole body. Most of the time when patients get angioedema, it is a type 1 hypersensitivity reaction to an antigen that was locally administered or could even be systemically administered. But we have a patient who is sensitized and has IgE that targets that medication, or whatever it is, and they get histamine release when they get exposed, and the histamine release is very profound and very rapid, and so they get the rapid onset of swelling from that vascular permeability that's induced by the histamine. So it's part of an allergic reaction. So when do we call it stomatitis medicamentosa? When do we call it angiodema? When do we just call it hives versus angiodema? They all have inflammation. So it depends on the clinical presentation. If it doesn't have a generalized rash or sneezing or asthma type thing, then we wouldn't just refer to it as a more generic type 1 hypersensitivity. If it is a reaction to a medication, but the presentation is just rapid onset swelling, there's no redness to speak of, there are no ulcers or that kind of thing, then we would call it angioedema. So the more specific pattern is usually the best answer. And stomatitis medicamentosa, that's also type 1 hypersensitivity mediated, is usually a little more generic. And this is a little more specific in the way it presents. Does that make sense? So that's kind of the way we do it. The most specific diagnosis that fits with the presentation is usually the better thing. Some patients get angioedema due to different mechanisms. All of the mechanisms will produce edema. When we studied acute inflammation that had increased vascular permeability, didn't we learn more than one mediator that could induce increased vascular permeability? Yes. So sometimes it's histamine release because of physical stimulus on mast cells, so they degranulate. It has nothing to do with type 1 hypersensitivity. Sometimes it's not histamine related, some other mediator altogether. Some people get the direct physical stimulus reactions to heat, cold, even stress and exercise, which is a little bit weird. I saw a lady here at the dental school many years ago who had a history of angioedema. She and her mother both would get it when they were too cold. Interesting. That's an unusual thing. The one that we have to be on the lookout for now is the bradykinin-mediated one. And there are some medications that can stimulate overproduction of bradykinin, where we kind of lose some of the checks and balances on our bradykinin cascade. And those are antihypertensive drugs that interfere with angiotensin-converting enzymes. Some of them are ACE inhibitors. Some of them they have a different name, but they're similar to ACE inhibitors. They're ACE, what's the other one? ARBs. That could be the receptor blockers. But they kind of do the same thing, and they allow overproduction of bradykinin, which can produce rapid onset of swelling that presents as angioedema. What is a common ACE inhibitor drug? Have you studied those yet in pharmacology? Lisinopril, and that's one of the most common drugs that produces this. Why is it important to know about that? Because the typical angioedema is an IgE-mediated type 1 hypersensitivity that's related to histamine release and responds beautifully to antihistamines. If your patient has bradykinin induced from lisinopril, you can give them all the histamine in the world and it will not do anything. So knowing which mechanism they have, what mechanism it is, dictates the treatment. This has to be treated differently and usually requires treatment by the physician. Sometimes it's inappropriate activation of complement. That one's less common. And least commonly is actually, oh, thank you. We're tired of cooking. The least likely mechanism is actually an inherited deficiency of C1 inhibitor, which allows unchecked production of complement, and those C5a, C3a can cause angioedema. So we looked at the complement cascade. C1 inhibitor puts the brakes on right here. So if you can't prevent inappropriate activation of C1, you go through the whole cascade. mechanisms. Question?
Can we just turn it down just a tiny bit because it feels so nice? Feels good, right?
It's a little
He
stuffy.
controls how much we turn it down?
Yeah, he is. Four?
Oh, you don't want to know what I want. I like it at 60.
Oh, not that cool.
So, yeah, we move on. We want to see what angioedema looks like. Angioedema very, very commonly affects the head and neck, which is why we study it. And one of the more common places to get a reaction is on the lips. Rapid swelling of the lips, particularly when it's an allergic reaction that's triggering it. But even the lisinopril patients with the ACE inhibitor problem with inappropriate activation and production of bradykinin often have lip involvement. The patients with the inherited pattern can have more extensive involvement, even internal organs. But these are both patients who had rapid onset lip swelling following administration of local anesthetic that they were allergic to. So these were patients that developed the soft, very soft, puffy lips over the course of their dental appointment. They came in with normal lips and they went home with big fat puffy lips. But it'll be gone in a day or two. The patient on the left, it's upper and lower lip, and that one was also a reaction to local anesthetic. Local anesthetics, it's easy, you just use a different anesthetic, but it's really important that you give the patient some antihistamine before they leave the office, because sometimes angioedema has progressive swelling that can go down the throat and cause laryngeal edema and suffocation and be an emergency situation. So give them some Benadryl before they leave the office and tell them if they develop any difficulty breathing whatsoever, they need to go to the emergency room immediately. It is an emergency situation. So then we have the patient on the right. And I have to tell you this story. He was a dental student when I was a dental student. We were not in the same class, but I knew who he was. And he had very nice, delicate facial features, kind of thin lips normally. He went on a hike with one of our faculty members. A nice hike in the summertime. And by the end of the hike, he had these big, fat, juicy, soft lips. Yes, lovely lips. And he said, oh, this always happens to me when I get too much sun, and that's why I wear hats. But he wore a hat that didn't have a big enough brim. It didn't protect his face enough, and so he got a reaction. But his was sun-induced. Isn't that beautiful? I love it. So I had his daughter as a student, and I showed this picture, and she didn't even recognize her dad. I think he doesn't go outside very much anymore. I love it. So lots of different things. Avoiding the further exposures to whatever is causing the problem is very, very important. Well, question, back up. What if the rapid lip swelling comes up in the dental office before the patient leaves the office and they complain about difficulty breathing? Send them to the ER? You should have something in your crash cart. What should you have? Epinephrine. Yes. They're having difficulty breathing. It's time for epinephrine. And if you don't have any or they don't respond, you call 911 and the ambulance comes and transports them. But if they're having difficulty breathing, they don't have time to drive themselves to the hospital or have their family drive them to the hospital. That is an emergency situation. So if they're breathing just fine, you can give them antihistamine and send them on their way with good instructions. But if they're having difficulty breathing, it's epinephrine. So we move on to our last immune-mediated disease. And this one is one that actually very rarely affects the oral cavity. I debate whether or not I should even tell you about it, but when it does affect the oral cavity, it almost always produces gingival changes. Who looks at the gingiva more than the hygienist? Nobody. Nobody. And once you've seen what it does to the gingiva, you don't really forget it. So you might be the first person who has a suspicion that the patient has this disease. The new politically correct term for this disease is granulomatosis with polyangiitis. It was previously called Wegener granulomatosis, but Wegener was a German physician during the time of World War II, and he worked with the Third Reich and did naughty things apparently, enough so that they decided he should not be honored with having something named after him. So they changed the name to granulomatosis with polyangiitis. But a lot of people still use the term Wegener granulomatosis. You see it very, very commonly. So that's what this is talking about. Wegener granulomatosis or granulomatosis with polyangiitis is a vasculitis syndrome. It's an immune-mediated disease that attacks blood vessel walls. This particular one affects small to medium arteries and veins, and only rarely has oral cavity lesions. It is interesting because it's a cell-mediated attack on the blood vessel walls that produces granulomatous inflammation. And we've talked about what granulomatous inflammation is. So if we did a biopsy, we would see granulomas. Those epithelioid histiocytes and lymphocytes and multinucleated giant cells. Yeah, it's really, really pretty. So that's why granulomatosis is in the name. It's because of the granulomatous inflammation. There are 3 places where patients typically, classically, have the vasculitis. Upper respiratory tract, lower respiratory tract, and kidneys. In the kidneys, the damage to the blood vessels can actually lead to kidney failure. And blood in the urine comes first, so they usually know they have some kidney involvement when they're peeing out pink urine. That's a big clue. Something's going on with the kidneys. What kinds of symptoms do you have with upper and lower respiratory tract problems? We'll look at that in just a moment. Almost always these patients are sick. So we don't see oral lesions in the absence of any systemic involvement. So I think that's important to keep in mind. It is immune-mediated. We don't know exactly what triggers it. We believe it's an autoimmune reaction. We diagnose it by presence of a specific antibody. It's called C-ANCA, and it's antibodies to a very specific antigen in the granules of neutrophils. So it's the anti-neutrophilic cytoplasmic antibodies. But didn't I tell you it was cell-mediated? That they have antibodies? What? How is that? There are a lot of autoimmune diseases that produce an antibody that can be used for diagnostic purposes, but the antibody isn't what produces the main disease changes in the tissues. I don't know why that is. So we check blood levels of the antibody for diagnostic purposes, but we see cell-mediated granulomatous inflammation in the tissues with this particular disease. So back to the clinical signs and symptoms. Recurring fevers, low-grade fevers for no apparent reason is common. Upper respiratory tract is nose and sinuses. Bloody noses are common. Term for that is epistaxis. Bloody noses. A chronic runny nose for no reason is a common sign. Congested nose, sinus pressure, sometimes purulent drainage from the nose or sinuses. So when you go to your physician with those complaints, what do they think it is? A cold, except it's been going on for weeks. Allergies or sinus infection. So typically these patients get treated for allergies and sinus infection and there's no improvement. Then they get the lower respiratory tract symptoms. Chronic dry cough is very, very common. Chest pain, hurts to breathe. Difficulty breathing, hard to catch your breath sometimes. One of the telltale clues is hemoptysis, which means coughing up blood. So if you have bronchitis or something like that after a bad cold or flu and you get secondary infections. You cough up blood? No. You might cough up green stuff or white stuff, but you don't cough up blood. So this usually does present with signs and symptoms that signify something significant going on, and patients go to the physician, but they are often treated for infection for a while, and it takes a while to figure out this is not an infection, this is not a chronic allergy that's going to respond to antihistamines and things like that. If there's a suspicion that it's Wegener granulomatosis, it is diagnosed by the blood test, or sometimes they end up doing biopsies as well. But sometimes they get oral lesions, and that's what I want you to know about. So I brought a couple cases. This was a 34-year-old who had a bump on her forehead. It was kind of a purplish bump, and then it cavitated, meaning it developed a hole in it. So it popped up and developed a hole in it over about a 2-day period. That's pretty unusual. Ordinary allergies don't do that. Infections don't do that. But this is what her gum tissue looked like. About the same time she started getting lesions on her skin, she started having a raw feeling in her sinuses. Her sinuses felt very full, and her gum tissue changed like this. Is that pretty dramatic? Yeah. So we call that strawberry gingivitis. And strawberry gingivitis is just the descriptive term for the appearance. It's not a diagnosis. The diagnosis is granulomatosis with polyangiitis. But you as a hygienist would notice that that is not in the range of typical gingivitis or periodontal disease. And that's why I think it's important for you to have seen it at least once. Because if your patient has this, you would want to get them treated right away. This is a deadly disease if it's not promptly diagnosed and treated. You have a few months window of opportunity to treat, otherwise they usually die. Treatment requires steroids and chemotherapy drugs for a full year in order to eradicate the disease. And if you start it too late, again, they could die. It's a very, very serious disease. No, it tends to develop kind of slowly. I had a patient a few years ago that came in with this. She was referred by ENT who had been working with her chronic sinus infections that weren't responding to antibiotics. And she had one gingival lesion. And the whole story together really sounded like granulomatosis with polyangiitis. So I talked to her about that. And she says, I've been looking online, and she says, I came to the same suspicion that that might be what it is. And she said to me, she said, Dr. Richards, I read online that if you don't start treatment within 6 months of onset of symptoms, you'll die. She says, I've had symptoms for 6 months. She says, am I going to die? As a dentist, we do not like hearing that. That is a very scary thing to hear from a patient. It's like, that's a question I can't answer. But we did get her back into treatment, and with ENT and rheumatology worked together. And last time I heard, she was doing well. So, and I was grateful, but man, that was a gut-wrencher question. I don't like those questions from my patients. So, anyway, there's another one, another patient, but see how really thick and overgrowth and grainy, it's called strawberry because it looks lumpy, bumpy like this. So hopefully you would recognize that and recognize that they have other complaints, not just gingival changes. Okay? And I think we are done with this topic. So you get a 10-minute break, and then Dr. Grandi comes in and starts the next topic. Oh, one last thing, real quick. So your first quiz is Friday over oral path topics, and the emphasis will be on picture cases. So if we have 10 questions, expect 8 of them to be with pictures and only 2 of them written things. So you're going to have to apply your interpretive skills. So I wanted to remind you that common things happen commonly. So if all other things are equal, it could be this or this. The best diagnosis is the more common one, and the next best is the lesser common. Don't forget, that's always a good thing to do. Unless there's something really specific about it that points to the rare thing, a common disease is a more likely diagnosis. No, the whole thing is oral path, but 8 questions will have pictures, and 2 questions just written. I think we have these questions.
I like it.
Nope. We do not work in multiple choice together. Period. So there are things that you just have to know. Most of them will be diagnosis, but we can show you the picture and you have to figure out what it is. We can ask you what causes this or what's the most common trigger, or we can ask you anything about it. So you really have to study your notes well so you can both recognize it and know the other things that you might ask.